Racing le para el de nuestro
شكلها استراحة. كده خلت الدوم. أنا عارفة اشتغلي عندك. أنا برضك عندك أنتي القصة تحت عندي نفس الشيء.
هم كيف هم
شوفي ايش نحط.
هذه أختها توفت.
إيه Just going for her, what you want for her. Constant work.
ازاي بقى هنعمل دلوقتي على زوم؟
انا هوقف بس لمده دقايق وانا هظبط تاني.
كتير. الكونكلوجن بتاع الكلام ده واللي اتاكد في القشري على الرغم من بعض الاستاذ دي كمان كان فاهم القشري، انما الكونكلوجن العام ان الروتين يوز اوف ميتفورمين مش افكتيف في اليوزج بتاعنا لحد يوز فور روتين يوز ان كيسز اوف سيكنس، وبالتالي هنستعمله ومش هنستعمله اوفر مش هنستعمله الا لو انا عندي بعض البريكوشنز اللي ممكن نتكلمها في الدي سي او، سبيشالي في الحالات اللي فيها دي سي او انسولين ريزيستنت وكده. ممكن يبقى الهدف بتاعنا بعض الاوبريان هايبر ستيميليشن عشان الافكت بتاعه على الفاسكولار انسيليكول ريسبتور اكتر. another randomized control study اتعملت على 13 another Cochrane review اتعمل على 13 randomized control study، وبدأوا يقيسوا في اللونج agonist بروتوكول على اللايف بيرث ريت insufficient data. ممكن يزود في بعض الاستاديز لكن بعض الفترة لا. الاند ريزلت بتاعهم او الاند بوينت او البرايمري اوتكم بتاعهم كان مختلف، عشان كده ما قدروش يحطوا فاينل كونكلوجن. الحاجة الثانية في الشورت بروتوكول بيريديوس اللايف بيرث ريت. مفيش عندنا داتا كتير على الكلينيكال بريجنسي ريت. الاوفيريان هايبر ستيميليشن الحاجة الوحيدة اللي ممكن يكون متفق عليها ان في كذا ستادي او اكثر من وان ستادي بتقول ان ممكن يأفكت المسكارج ريت، بيقول ما عندناش داتا افيلابل، وبالتالي القشري قالت ان الروتين يوز الداتا مش ريكومندد بالنسبه للفورم في حالات الاستثناء. الجروث هرمون واحد من الحاجات الكتيره اللي اخذت بابليكيشنز كتير وعدد البيشنتس اللي اتعمل عليهم كتير، انما اليوز اوف ات از روتين في حالات البور ريسبوندر بالذات از نوت ريكومندد فور اتس يوز برضه بنفس النظريه. التستوستيرون وراشونات كتير ندي تستوستيرون قبليه نقيس ما نقيسي وندي او لا. القول الاخير بتاعه ان احنا عشان نديه قبل الكنترول اوف هايبر ستيميليشن از نوت ريكومندد، لانه ما بيزودش، ما فيش ايفيدنس ان هو بيحسن من النتائج بتاعتنا او ان هو بيزود الكلينيكال بريجنسي ريت. دايهايدروستيرون ستيل برضه بالريكومنديشن بتاعت القشري نتيجه ان ما فيش كونسيستنت داتا على الاس يوز. في بعض الاستاديز اللي بتقول ان هو بيزود بعضها لا. الاوفر اول كونكلوجن بتاعهم بيقول ان احنا الافكت بتاعه مش واضح، وبالتالي ما نقدرش يبقى في ريكومنديشن واضحه للاستعمال بتاعه، سبيشالي في الدوز بتاعته، وسبيشالي الحاجه الثانيه ان هو الديوريشن كمان مختلفه كتير ما بين فيري شورت ديوريشن وفيري لونج ديوريشن، فكانت من الحاجات اللي هي اخر حاجه اللونج تيرم جي ان اتش اجونست ثيرابي بيفور ذا اي بي اف سايكل. قعدنا سنين كتير نقول ان من افضلهم في الاندوميتريوزز هو اللونج اجونست او سميناه الترا لونج بروتوكول فور 3 مانثs اند سو اون، وبعدين بدانا نقول في انديفيدواليزيشن للبروتوكول ده بحسب الاوفير ريزيرف و دلوقتي اخر ميتا اناليسيز ببلش ريسنتلي بتقول وبرضه ستيل هم نفس الاوثرز ومنهم استاذنا الدكتور سلام بيقول ان كونتراست للفايندنج بتاعت قبل كده لما بداوا يشوفوا اللونج الفتره اللونج بروتوكول ده على اللايف بيرث ريت بيقلل اللايف بيرث ريت على اللايف بيرث ريت حتى في الكاتيجوري بتاعت الاندوميتريوزز 1 و 2 و3 و4 ستيل برضه الشيفت زي ما احنا شايفين الناحيه الثانيه، فهو ان فيفر اوف نوت يوزنج ذا الترا شورت بروتوكول. الكومبليكيشن ريت ايكويفوكال however slightly increasing مع اليوزج اوف الكلينيكال بريجنسي ريت انسيجنيفيكانت، وبالتالي مفيش عشان كده الستيتمنت بتاعتهم طلعت ان مفيش في uncertainty about whether to use the long agonist protocol عشان الافكت بتاعه وعشان الكومبليكيشن، و ان حتى على المالتي بريجنسي وعلى المسكارج ريت والمين نمبر اوف اوسايتس كل الكلام ده مفيش certainty of the evidence، وبالتالي يبقى البروتوكول هنا مش من الحاجات الفيرست اوبشنز بتاعنا. هنروح الاثنين لاجونست ولا الانتاجونست. هنلاقي الستيتمنت الثانيه بتاعت القشري couple of years ago بتقول ان احنا ممكن الانتاجونست is not inferior to the agonist so can be used، يبقى individualization للحالات هتبقى very very important. البريتش فيرتيلتي سوسايتي كانت مطلعه جايد لاين وعملت له اندورسمنت ليتر اون، وقالت ان ما في lack of robust data او evidence for most of the adjuvants namely aspirin, heparin, growth hormone, vasodilators, estrogen inhibitors. كتير من اللي احنا قلناه النهارده مش موجود في الايفيدنس بتاعتي. احنا طبعا ما اتكلمناش عن aspirin, heparin وكده ان هو عاده بيتاخد في adjuvant with the cycle not pre-treatment. So the take home message for today actually is that we have two types of pre-treatment. We have the hormonal and the adjuvant. For the estrogen, not recommended. Progesterone is not recommended. Combined pills is not recommended, except for not recommended. Most of the adjuvant is not recommended before, and the GnRH agonist, the ultra-longer protocol for the cases of endometriosis is not recommended so far. Thank you so much.
Thank you very much, Professor, for this very high scientific talk. Our next speaker is Professor Dr. Salah Rashid from Asyut University. Professor Salah is Professor of Obstetrics and Gynecology, and he is one of the members of their advisory board. We welcome him today, and he is going to present androgen in infertility.
دكتور صلاح في سوهاج يونيفرستي، بس هو ابتدى معانا يعني بقى اسيوط سوهاج يعني. لكن هي از بروفيسور ان سوهاج يونيفرستي.
شكرا يا باشا، شكرا لمدى المدرس، شكرا دكتور عبد الحميد الدين. انا بشكر كل الفني اللي شارك في الموضوع. As we are run out of time, have more concise. أنا كنت عاوز أتكلم عن الأندروجين، بس أنا خليتها more specifically about the dehydroepiandrosterone for poor responders, a scientific contention, a scientific battle or struggle. أبدأ قبل ما أبدأ المحاضرة معلش حاجة بسيطة كده في عيادتك بينك وبين العيانة بتاعتك، اختصر الديهايدروepiandrosterone زي ما أنت عاوز، قول ده هي أو غيره، إنما in the scientific vision it is called Okay. The content of this presentation is there is a rationale for the use of DHA in infertility. The clinical evidence, which with the use of DHA, the clinical evidence again is the use of DHA, and how to solve the conflict between the researcher and the clinician regarding this topic. What about the rationale about the use of DHA? لغاية أوائل التسعينات الأندروجينز are considered detrimental to the process of folliculogenesis. الكلام ده اتشينج تماما، والبوليسي دلوقتي is sufficient androgen is absolutely necessary for normal follicular development. خلينا عارفين ال DHA is not androgen, it's a pro-androgen, but it is the mother of all these hormones. كلنا برضه عارفين السيل المشهوره زي السيل الجونادوتروبين دلوقتي الكلام ده اتغير تماما. الثيوري دي somewhat false and it is replaced by what's called two triangular hypothesis. التو سيل ثيوري بتعتمد just على الاف اس اتش والال اتش. قال لك لا الكلام ده مش هينفع. في الاف اس اتش والال اتش don't responsible about the latest stage of folliculogenesis. انما في early stages of folliculogenesis, الأندروجين is on the top of this pyramid together with الانتيمولاريان هرمون زي كمان اف اس اتش and estradiol. الأندروجين receptors are expressed at all stages of follicles and also in the endometrium. So it's very hard about in the process of implantation. احنا عارفين ان الفيرست organ in the human body which undergo aging in the ovary. It undergo process of aging even inside the uterus. الترم ovarian aging بيعتبروه حاجة not specific. هل الأوفايت هل بيحصل لها aging ولا الأوفاريان مايكرو انفايرمنت هي اللي بيحصل لها aging؟ فرق كتير. لو كانت الأوفايت دي aged معناها any treatment will never affect it. فالكونسيبت كله changes. The somatic cells of the ovary just undergo aging, but resting follicles, primordial follicles never age. They either die or remain dormant. It looks like a frozen embryo. The eggs in storage or primordial follicles are just suspended in time. زي حاجة ماشية في الفضاء. Like a frozen age. أكيدوا بالكلام ده. إذا كانت الأوفايت دي age معنى كده the treatment would never recover these damaged oocytes. So the process of ovarian aging is actually a microenvironmental aging, not aging of the primordial follicles. The DHA والtestosterone الاثنين decrease with aging and in women with poor ovarian reserve. لدرجة واحد مشهور جدا one of the most honest and one of the most trustable reproductive immunologist all over the world which is Norfolk Fleischer ده شغال في نيويورك طلع conclusion وقال ان البور ovarian response البور ovarian responder represents an androgen deficient state. وال DHA he added that the DHA can convert the age microenvironment into a younger properly functioning environment. الكلام ده من حوالي 8 سنين. في السنه اللي فاتت تقريبا او 2019 واحد صيني شغال في امريكا قال له لا انت بقيت هايبرفوليك. فور اوفيريان ريسبونس ده عباره عن اندروجين ديفيشنسي قال له لا انت خليك في الوسط وقول androgen is one among many changes which at least partially preserve it. لو بدأنا القصة بتاعت الدي اتش اي بدأت ازاي؟ هذا experimental patient driven. This is no particular كان عندها habitual abortion وعاوزة تعمل screening for unemployment قبل تعمل embryo freezing. The first cycle طلعت only one poor quality. But I'm interested to go into another cycle. Professor Fleischer refused and advised it hard for all. Believe or not, you have the right. After 3 months, she came to him and she insisted to pass into another trial. And after 6 consecutive cycles, she released 66 embryos. Fleischer scratched his head and he said that I scratched my head. What happened? Because the patient told him, I told a secret for you, but please don't think about it. I went to the library and searched for some medication which may improve the ovarian response and found the DHA among these ones, and she took it. Why DHA in particular? Because it's available over the counter without medical prescription in use. From here started the point of research regarding the
الحاجة دي
اللي فاتح المايك ممكن يسكر.
اللي فاتح المايك خليه يسكر المايك لو سمحتوا. is doing the same thing, the same experiment, okay, over and over again, repeating different, and lastly, I'm always habituated to finish up my presentation with this mortal statement, knowledge, just like I'm discussing the more picture you put, the more picture you can consent.
Decision around the decision for our variable processors will be delayed after the session to be to have around 10 minutes for discussion if there is any. Okay.
بصراحة مين اللي جاي؟ حضرتك في آخر المحاضرة بس كلامك الجزء بتاع DHA to be prescribed ولا لا؟ تاني حاجة before I will use it because I don't have another option. I don't think this will work in medicine because using any medication means that money will pay for the patient. Check yourself or the patient. If you want to use something that you are not sure about its benefit, just to try, pay it yourself. Don't allow the patient to. This is my
شكرا استاذ عبد الجليل حضرتك. انا قال title of my presentation is scientific contention في راجل clinician حضرتك
انا وقفت ال10 دقايق دول عشان ندخل على عشان كده احنا مصابين دول هيتاجلوا للساعه 4. طيب يعني الاول هنخش دلوقتي على انجلترا، فانا عايز اعرف انتوا دخلتوا على النت ولا لا؟ انا اللينك اللي هو بعت اللينك اللي احنا باعتينها العرض اللينك اللي بعتها لك على الواتس بعتها له عشان يسالني على اللون.
ممكن اكون غلط انا بس
اللابتوب عكس عليه ممكن
لا
الدكاتره بس عايز صلاح ثانيه واحده يا باشا اتفضل. بس عايزين نحافظ على ان كل واحد لابس ماسك ما يدعوش الدكتوره اللي هناك مش لابسه ماسك لازم تلبسهم. بعد اذنكم برضه الموبايلات فعلا عشان احنا دلوقتي بعد 10 دقائق نخش على البرنامج سيشن، فبالتالي عايزين نظهر مش كل شويه اتفضل يا باشا.
دكتور صلاح انا بشكرك جدا على المحاضره بتاعتك، وطبعا انا اي نو جليتش كويس قوي دايما انا بحاول سكراتش يظهر سكراتش هاد عندي سكراتش لميكم، وبعد كده الناس كلها قالت ان اوكي. حضرتك النهارده بتقول ان هو هيستفيد ايه الناس الصغيره. الحاله الوحيده اللي جت لايف عملت لهم سنها فوق 40 سنه. الكلام ده مش ماشي مع بعض. احنا نفسنا في حاجه فعلا تزود. انا متمسك جدا ان ده تستوستيرون. في نقطه بس مهمه جدا وارجو ان حد يصلحها لي. قياس التستوستيرون هل هو الفري ولا التوتال؟ اذا كان قياس التستوستيرون معروف ان قياس التستوستيرون ده من اصعب واغلى ما يمكن، اللي بيطلع لنا ده مش مظبوط. يعني هم مخابر او اتنين في امريكا كلها بيعملوا التستوستيرون صح. اعتمدت على الناس اللي انا بقيس التستوستيرون، انا بقيس التستوستيرون عمره بيطلع صح. هو التستوستيرون ايضا
يا باشا بص، هو دلوقتي السيشن بتاع برمنجهام هتبتدي. هو دلوقتي البرمنجهام بيعملوا
بس مفيش قاعده في الميديسن ثابته. احنا بنقول لحضرتك ان السبيكتر في اليانج وومن اسمها كده ان بوسيبل ان عيانه اولد ايج النتيجه معاها. مفيش قاعده في الميديسن حضرتك ثابته. في حاجه اكسبشن بس خليك ريتش عليهم
One to ask you applicable to based before it is applicable to do احنا السؤال اللي بيتكلم على البوست بتاع الجينوم اناليسيس. انا عايز اقول ان اول جينوم اناليسيس اتعمل بروجكت اخذ 13 سنه وكلف 100 مليون دولار. النهارده الكرنت سيكونسرز
Professor Ghosh, yes, we are ready. You can share your screen and we will start within 5 minutes. Do you hear me? Professor Jay.
Yes, I can hear you. I'm just bringing up her presentation now.
Yes, I made you as a co-host so you can share your screen and we are ready to start when you're ready.
Hi everyone, I'm Shirin Meher. I'm a consultant in fetal maternal medicine working at the Birmingham Women's Hospital in the United Kingdom. And I am the lead for the multiple pregnancy services at the hospital, and I also provide the interventional service in the fetal medicine unit with Professor Mark Kilby. I'll be talking to you about the recent advances in multiple pregnancy over the next 25 minutes or so. I will be covering the incidents and risks. I will be talking a bit about the guidelines, potential complications, and their management. In the UK, 1.5% of pregnancies are multiple pregnancies, and globally it's about 1.2%, with a recent 33% increase. This increase is largely secondary to infertility treatments as well as advanced maternal age. And the Human Fertilization and Embryology Authority said that multiple births were the single greatest risk of infertility treatment. In 2007, 1 in 4 IVF pregnancies were resulting in multiple pregnancies. And so there was a drive to reduce the rate of multiple pregnancies by bringing in a number of policies, and this has certainly been successful to some extent, and multiple pregnancy rate has come down to 10% in 2017. However, there are ongoing concerns about increasing incidence with increase in IVF cycles with higher success rates, to blastocyst transfers, and cross-border assisted conception in countries where there are less stringent criteria about the number of embryos that are being transferred. I just wanted to remind you about the importance of zygosity and chorionicity when it comes to managing multiple pregnancies. So when there is dizygotic or non-identical twins where 2 sperms have fertilized to ovum, this results in dichorionic twins. But where there are monozygotic or identical twins, these have come about from fertilization of 1 sperm with 1 egg. This can result in dichorionic twins or monochorionic diamniotic, monochorionic monoamniotic, or conjoined twins, depending on when the embryo splits. But the important thing to understand is that perinatal risks increase with monochorionicity and monoamniosity. The risk of complications in twins is much higher compared to singletons in pregnancy loss rates, as well as fetal growth restriction, preterm birth, congenital anomalies, and risks to the mother are increased as well with preeclampsia, diabetes, and cardiac events. So the risks in dichorionic twins are double to 5 times that of singletons, but the risk in monochorionic twins can be as high as 5 to 10 times compared to singletons. There are now a number of recent excellent guidelines that talk about management of multiple pregnancy, and most of these are consistent in what they recommend, and they come from the NICE institution, the ISWOG, and the RCOG. All of them emphasize the importance of establishing chorionicity and dating early in the pregnancy. Chorionicity is established looking at the number of placenta, the lambda sign in dichorionic twins, T sign in monochorionic twins, looking at the thickness of the intertwin membrane, which is thicker in dichorionic twins, and fetal sexing. So discordant sexes are consistent with dichorionic twins. If it is not possible to establish chorionicity, because, for example, if a woman's booked in late, despite specialist review, then the advice is to treat them as monochorionic twins. Dating should always be done using the crown rump length of the larger twin, because the smaller twin may be affected by early onset fetal growth restriction, and we may not be able to establish this till later on. It's important to label the twins in terms of where they're lying with respect to the uterus, and it is very important to be consistent throughout pregnancy with this nomenclature that's been assigned. Down syndrome screening can be done at the same time at the scan with first trimester combined screening, which can be offered to twins. So important to remember that the results are obtained for each fetus in dichorionic diamniotic twins, but a single risk per pregnancy is obtained for monochorionic twins because these are identical, and this is established by averaging the NTs of the two babies. The detection rates are similar to singleton pregnancies, but the false positive rate may be slightly higher. So the twin pregnancies and triplet pregnancies are more likely to be offered invasive procedures. Where the first trimester screening has been missed, second trimester screening can be, with the quadruple test, can be offered in twins. Detection rates for monochorionic twins are comparable to singletons, but detection rate for dichorionic twins is much lower, up to 50%. NIPT is becoming more available, and this is a much more accurate screening test, but there's less data available in twins. It does have a higher failure rate, but it tends to be more accurate in monochorionic twins compared to dichorionic, and studies are now reporting detection rates as high as 94 to 95%. Where the risk does come back as high risk for chromosomal abnormalities, it's really important to refer to a fetal medicine unit to discuss invasive testing, because the counseling can be complex. We need to discuss whether to sample one or both sacs and discuss the higher risk of miscarriage with sampling both sacs, which may be as high as 1 to 2%. Generally, we recommend sampling both sacs because dichorionic twins are most often non-identical, but can be identical in 10%. And monochorionic twins can rarely be genetically non-identical because of heterokaryotypia secondary to post-zygotic non-disjunction of chromosomes. It's critical to map the babies accurately, because if the results are discordant and the couple wish for a selective reduction, then it is important that to be sure that we are reducing the baby with the abnormal chromosomes. So it's important that the clinician who does the invasive testing should also do the mapping and the selective reduction to reduce the risk of mistakes. Anomaly scans are recommended around 20 weeks, and growth scans should be done in dichorionic twins 4 weekly from 24 weeks, and in monochorionic twins and triplets 2 weekly from 16 weeks. For monochorionic twins, it's important to monitor for twin-twin transfusion syndrome by looking at discordance in microvolumes. It's contentious whether we should be monitoring for twin anemia polycythemia sequence, which is a chronic form of transfusion. However, because this needs MCA Doppler to detect fetal anemia, which has implications for resources and training, but also the optimum management is not known. And so not all guidelines recommend MCA Dopplers while monitoring with regular growth scans. Delivery is recommended around 37 weeks in dichorionic twins, 36 weeks in monochorionic diamniotic twins, and at 35 weeks in uncomplicated trichorionic triamniotic triplets. This is because there is an increased risk of stillbirth beyond these completed weeks for these twins and triplets. For monochorionic monoamniotic twins and non-trichorionic triplets, it's recommended that they be delivered earlier between 32 and 34 weeks because of a sudden unpredictable risk of death in these twins. For mode of delivery, the twin birth study in 2013 did not show any significant difference in outcomes between planned vaginal birth or elective cesarean section, although about 40% of women with vaginal birth did end up delivering by emergency cesarean sections. So the recommendation is that DCDA and MCDA twins should be offered vaginal birth if the presenting twin is cephalic. But for monochorionic, monoamniotic twins and triplets, a cesarean section is recommended because of the complexities around delivery in these multiple pregnancies. Just going into complications, preterm birth is a common one with over 50% of multiple pregnancy delivering preterm. And although we know that a short cervical length does predict preterm labor, there is no effective intervention for prevention of preterm birth and multiple pregnancy, despite lots of research in this area. So guidelines do not recommend routine cervical length screening in multiple pregnancy, and they do not recommend routinely offering progesterone, Arabin pessary, cervical cerclage, or tocolytics. Steroids are not recommended in an untargeted way, but antenatal steroids are recommended where you think the risk of delivery before 34 weeks is high, or an elective cesarean section is being planned that is preterm. The risk of congenital anomalies is higher in twins compared to singletons, and monochorionic twins have double the risk of dichorionic twins. There are certain systems that are more affected, particularly the central nervous system with neurological tube defects are not uncommon. Management of discordant anomalies includes expectant management, where the anomaly is not lethal or severe, and also where this is what the parents wish. However, with severe or lethal abnormalities and where parents wish for selective reduction, this is certainly an option. In dichorionic twins, this is done by an intracardiac potassium chloride or lignocaine injection. But anytime we do any invasive interventions, there is a risk of miscarriage of the whole of the pregnancy, and that's about 7% in the first trimester and 15% in the second trimester. If the couple want to avoid the risk of miscarriage, the option of a late termination of pregnancy is there at around 32 weeks, which only carries a preterm labor risk of about 4%. But you have to weigh that against the psychological impact of waiting on the couple. And also with twins, there is a potential risk of preterm birth and other complications in twins while the couple are waiting up to 32 weeks. Selective feticide can be offered in monochorionic twins, but the method is different because these fetuses share a vasculature. And so the procedures that are recommended are intrafetal laser ablation or radiofrequency ablation at earlier gestations, or cord occlusion at later gestations. These procedures are certainly a little bit more complicated. The needle thickness is thicker, and so pregnancy loss rates are higher, can be up to 20%, with rupture membranes up to 10%. The surviving co-twin can also have neurological sequelae in up to 15%. Where there is not a planned selective reduction done, sometimes you can have spontaneous loss of a single twin, and this has consequences for the co-twin, particularly in monochorionic twins, if this happens after 14 weeks gestation. Most often, a single twin demise happens after twin-twin transfusion, but it can also happen in a spontaneous way, and this can result in death of the co-twin in 15% of monochorionic twins and neurodevelopmental morbidity in up to 21%. And this happens secondary to a sudden severe hypotension with acute transfusion of blood to the twin that has passed away, with thromboembolic events that may develop later on. In contrast to this, the complication risk of death or neurodevelopmental morbidity in the co-twin is much lower in dichorionic twins, varying from 2 to 3%. The management of single twin demise depends on chorionicity and the gestation. With dichorionic twins, expectant management is certainly the norm at early gestations, but delivery may be considered around term. With monochorionic twins, the best option is unclear because of the potential impact on the co-twin. We arrange for an ultrasound scan to check for fetal anemia of the co-twin, and this may help guide management. Delivery will depend on the gestational age, so very preterm delivery even if we deliver, can result in a neonatal death, even if we avoid a stillbirth. And so important to weigh those risks and benefits. Where the pregnancy is ongoing, we recommend a fetal MRI scan at 4 weeks to assess for neurological morbidity that may develop in the co-twin. We increase the surveillance with ultrasound scan CTG, and we recommend postnatal imaging to check for neurological morbidity in the surviving twin. A common complication of monochorionic twins is twin-twin transfusion syndrome, which develops in up to 15% of monochorionic twins. This is an unbalanced transfusion of blood from one fetus to another, and the fetus with the hypervolumia develops a polyhydramnios, and this can lead to overload on the heart with cardiac dysfunction that may develop. The other baby or the donor develops hypovolumia and oligohydramnios. It's not uncommon to see selective growth restriction in the donor as well. But twin-twin transfusion syndrome accounts for at least 80% of all monochorionic twin perinatal mortality. Quintero staging has been around for a long time to stage the severity of twin-twin transfusion. The important thing to emphasize is that when we get to stage 2, where the bladder is not visible in the donor, this is highly likely to progress. And when it progresses, if we do nothing, there is a 90% risk of losing one or both babies. And so this is the stage where stage 2 and 3 is where intervention is certainly recommended. Management options include fetoscopic laser ablation, which aims to coagulate the blood vessel anastomosis between the two babies and addresses the underlying pathology. Amnioreduction has been used for a long time. This drains off the excess fluid in the baby with polyhydramnios, but this doesn't address the underlying pathology. Termination of pregnancy can also be discussed with the couple. 2 small trials have compared fetoscopic laser ablation with amnioreduction, and although they didn't find a clear difference in the risk of survival, they did find that more babies were alive without neurological recommended treatment for transfusion syndrome. Amnioreduction has a place where there's no access to fetoscopic laser ablation, or after 26 weeks, where fetoscopic laser ablation becomes much more difficult technically. Fetoscopic laser ablation involves identification and coagulation of each anastomosis. And now the Solomon technique is used that connects the dots of coagulation for each of these anastomosis so that you have complete coagulation along the vascular equator and a disconnection of the anastomosis between the babies. This solemnization technique reduces the risk of recurrence of TTTS and also of a chronic transfusion developing with TAPS. Fetoscopic laser ablation has an 80% success rate for having at least one baby that's born alive. But obviously this varies across different centers. Laser treatment also reduces the risk of cerebral morbidity from 50% to less than 10%. The other complication unique to monochorionic twins is twin anemia polycythemia sequence, or TAPS. This is a significant discordance in hemoglobin in the two babies without Lycra discordance, secondary to a slow blood transfusion from the donor to the recipient. And it results in one baby being anemic with cardiac failure and high drops that may develop at one extreme. And the other baby has a hyperviscosity syndrome from polycythemia, and this can result in thrombosis and ischemic lesions. These babies, the anemic baby sometimes needs a blood transfusion at birth, whereas the polycythemic baby may need a partial exchange transfusion. TAPS is diagnosed with middle cerebral artery Doppler, peak systolic velocity. If it's more than 1.5 mom, that indicates anemia in one twin, and less than 1 indicates polycythemia in the other twin, but there is an absence of Lycra discordance in this condition. Staging is used to guide when we intervene, and stage 1 and 2 involve various increasing severities of anemia polycythemia. Stage 3 is where we have abnormal Dopplers in the umbilical artery or ductus venosus. Stage 4 is where there's high drops, and stage 5 is death. So we generally tend to intervene around stage 3. The management of TAPS is unclear. We can manage it expectantly at earlier stages. An intrauterine transfusion can be considered, which corrects the anemia in the baby, but may actually worsen the hyperviscosity in the polycythemic recipient. And so the recipient may actually need a partial exchange transfusion with saline being infused. Fetoscopic laser ablation is also an option, but this can be technically more difficult because there is no polyhydramnios to aid visualization of the anastomoses. And it does also carry a higher risk of complications such as preterm rupture of membranes. Delivery can be considered as well as a selective feticide. And generally what we tend to do is in earlier stages, we manage this expectantly, but in more advanced stages, 2, 3, and 4, in earlier gestations, we tend to do laser treatment. At later gestations, beyond 32 weeks, we tend to deliver. But between 28 and 32 weeks, that's when we consider blood transfusion and exchange transfusions. Selective fetal growth restriction is a common complication in twins, particularly monochorionic twins, which may happen secondary to unequal sharing of that single placenta. The definition of selective growth restriction is where one fetus has an estimated fetal weight below the 10th centile, or there is an estimated fetal weight discordance between the two babies of more than 25%. The obvious risk here is of perinatal loss, and in monochorionic twins, the death of the co-twin and neurological injury can also result. We recommend that estimated fetal weight discordance more than 25% should prompt a referral to a specialist fetal medicine center, particularly in monochorionic twins, to discuss the options for management. Selective growth restriction in twins is classified as type 1, 2, or 3 based on the umbilical artery Doppler blood flow. So where there is positive end diastolic flow, it's associated with good outcome, and this is type 1. Type 2 is where there is persistent, absent, or reversed end diastolic flow in the umbilical artery. This is associated with high deterioration rates and high intrauterine death rates, but it progresses in a predictable way, and this allows us to optimize the timing of delivery. Type 3 is where you have intermittent absent a reversed end diastolic flow. Although the deterioration rates are lower and the risk of intrauterine demise is lower at 15%, the problem with this is that pregnancy loss can happen quickly in an unpredictable way, so it can be more challenging to manage. Management option for selective fetal growth restriction are determined by chorionicity and the gestational age. With dichorionic twins, we manage this expectantly, certainly at early gestations. We can deliver certainly beyond 32 weeks because the outcome tends to be good with lower risk of preterm birth. The difficult period is between 26 and 32 weeks, and this is where parental counseling is critical. The options in this stage is if there are advanced Doppler changes and abnormalities in the ductus venosus, there's a high risk of losing that growth-restricted baby. If the couple want to offer both babies a chance at survival, that's when delivery has to be considered. But that needs to be weighed with the risk of prematurity and its complications. The other option is to carry on and optimize the gestation for the well-grown baby, but then the couple have to accept the risk of losing that smaller growth-restricted baby. And these are difficult decisions to make for the parents. Monochorionic diamniotic twins are generally managed expectantly if the Dopplers are normal. If the Doppler is abnormal and the gestation is very early on, then we also manage this expectantly. But there's always a risk of progression and decompensation with fetal loss in these cases. Delivery is generally recommended with normal Dopplers between 34 and 36 weeks, and at 32 weeks if the Dopplers are abnormal. Interventional therapy can be considered for selective early onset fetal growth restriction in monochorionic twins before 24 weeks. We only offer this when there are clear signs of decompensation in the growth restricted baby with an abnormal ductus venosus Doppler, because these procedures carry a risk of miscarrying the whole of the pregnancy as high as 15%. The methods that are available are selective reduction or fetoscopic laser coagulation. These methods have been compared in studies. And so fetoscopic laser ablation, the advantage is that it does allow a chance of survival for the growth-restricted baby, whereas a selective reduction would aim to stop the heartbeat of that baby and protect the bigger baby. Laser coagulation, however, is not always possible because there is no polyhydramnios to aid visualization. The survival overall is comparable between the two techniques, but there is a trend in higher survival of the well-grown baby with selective reduction. The technique used really depends on what the couple want. There are couples who would not want a selective termination at all, and there may be couples who would rather optimize the chance for the well-grown baby and take the risk of losing the other one. So these are the things that need to be discussed with the couple. And lastly, I just want to emphasize the importance of organizing care in a women-centered way. We've spoken about so many complications of multiple pregnancies, and when you talk about these complications to the couple, obviously this generates anxiety. And so it's important to counsel these women in a sensitive and supportive way and optimize their health. So they are at risk of anemia and postpartum hemorrhage. So it's important to optimize the hemoglobin levels throughout pregnancy. We should be offering them aspirin if they are eligible for aspirin therapy to reduce their risk of preeclampsia. They need to be warned about the potential risk of operative delivery and high risks of cesarean section in around a third of multiple pregnancies. And what we know is that continuity of care with a core team of multidisciplinary service providers does improve outcome in multiple pregnancy. And I just want to thank all of you for listening, and thank you very much for the opportunity to present at this conference.
Professor Simon, you can share your screen, sir.
Okay, you should be able to now. Can you see me?
Yeah.
Okay. So, what do you want me just to start?
Yes, you can start now, sir.
Okay, 1 second. All right, I can't see myself, but you can see the screen, yes?
Yes, I'm seeing you, but you can share your screen if there is a PowerPoint.
Oh, I am sharing it, I thought. Hang on a second. Let me go back to share screen. Oh, share screen.
The green one, the green button.
Yeah, no, I've got that. I'm just trying to see what to okay.
Yes.
Oh, it's this.
Excellent. Yes.
Now, do you see the full? Do I put it on video or do I just leave it like this?
Put it. Yes, this.
So
okay,
I've got.
Excellent.
You can see
you
that.
Can
yes.
Start now. Yes.
All right.
Excellent.
Right. Thank you very much for the honored invitation to the meeting today, and I'm going to talk about embryo selection in human IVF. Primarily to maximize live birth rates, but I'm also going to finish off with some novel stuff as well. Now, I've been involved in IVF for 40 years now, more than, and we have always been interested in the embryo, knowing that it's not always going to implant or necessarily make a baby. And once we started, of course, in the prospects of producing multiple embryos, then selection became important. And here is a photograph from the World First Congress in 1981, with the only pioneers available trying IVF from all around the world at the time. And this is on the lawn at Bourne Hall. Here we see, you can maybe see Howard Jones sitting here, Alex Laparta, being asked a question by Alan Trounson, and Professor Lars Hamburger raising his hand, and some old slides, if you remember slides, some old photographs of slides. We're dealing with the problem then of the embryo and its viability. And in fact, this is from 1981. We published a paper in American Journal of Obstetrics and Gynecology, and we were really quite obsessed in those days at looking at the growth rate of the early pre-implantation embryo as a possibility of trying to understand its viability. And then some quite shocking data came out by Ros Angel and her group in Edinburgh between 1984 and 1986, looking at metaphase spreads of human embryos, only to determine that a surprising number of them were chromosomally abnormal. And so that led to this clinical imperative, which took about 30 years before we could get to really developing it, of trying to see whether we could study a full chromosome complement in the human embryo before its transfer. And of course, as we now know today, and we'll see in my talk, this lingers on as to whether or not it's a technology that will help improve live birth rates per treatment cycle. But in the very beginning, here in the top left of my slide, was the first IVF baby, Louise Brown, as you all know. And that was on the natural cycle with a single 8-cell embryo. So actually, we didn't need to select at the very beginning. But once others started to come into the fold, and in fact, before Louise was born, stimulated cycles were attempted, but that's another interesting story with a huge amount of failure. And then, of course, we had the success rates coming in from the Melbourne group in Australia, then the Joneses in America, and then actually very early on, before even Australia, and just a few months after Louise Brown, there is the success in India. And then, of course, the work by Friedman and Testar in Pasteur. These groups were using stimulation. So all of a sudden, we go from the single embryo that kicked off the IVF phenomenon to multiple embryos being available under the microscope. And what do we do in those days? we transferred multiple embryos because it showed that we had multiple better success rates. But of course, we now know today it's bad practice because we end up with multiple pregnancy. But importantly, we can achieve with one single blastocyst live birth rates today higher than we used to get transferring 3 embryos back in the very beginning. So what do we have available today? A whole raft of technologies that are being looked at, being used, being researched to see whether or not we could have predictive factors. We have now moved on to the area of time-lapse imaging. I'll talk a lot more about that. We've been doing some research on cytoplasmic flows because we understand post-fertilization now that the actual generation of a particular pattern of cytoplasmic flows tells us whether or not that oocyte will make a viable embryo. Calcium flows as well, and of course chromosome screening are all just a few of the really cutting-edge technologies that are being used for selecting embryos. And indeed, we see here from Zev Rosenbach's, who had a statement in his Fertility and Sterility article in 2017, that biomarkers of embryo viability is a search for the holy grail for embryo selection. And it's a major challenge that is facing our field. But he also said, which is quite right, and I'll mention this a little bit too, that one can't ignore the fact that uterine receptivity is in part responsible for implantation efficiency. And I will make a little comment here about what I think is a possibility of some failures, which is due to placental insufficiency rather than actually directly the uterine receptivity is referred to here. And of course, the great and the good in clinical embryology, they got together in Istanbul, published this in RBM Online in 2011, about what we should be looking for in screening human embryos. And this is basically built on 30 years of correlation of various things. Oocyte dysmorphism is often used, not so much now. Zygote scoring used to be very significant. Then, of course, we've got the cleavage scoring, which many people still do. They look at cytoplasmic fragments, they look at uneven blastomeres, etc. And then we move on to blastocyst scoring, and of course, the Gardner scoring, as some people like to use it, for whether or not you've got an embryo of high viability, or certainly a good grade is meant to be correlated to high viability. But none of them really have an enormous accuracy for several reasons, because of course it's not everything in the embryo, but it's a very large part. So today, what do we really have? We have today the chromosome screening, as we well know, and we have time-lapse imaging where a lot of work is being done. There are those that are trying to establish whether there are gene anomalies which can be looked for, but finding a signal in the noise amongst a raft of genes in terms of embryo viability is, of course, very difficult. And then we've got metabolic assessments, the quiet embryo hypothesis, for example, as well. And I would still say today that largely many rely on morphological scoring, which we know is a very rough and ready tool, not particularly accurate. So what do we have, I think, fundamentally to rely on as a real potential prognosticator? We have ploidy and we have time-lapse imaging. There are some imaging procedures that believe that if you can predict whether an embryo blastulates, that's a good technology. But I think I would offer a word of caution when one considers just prediction for blastulation, because that can be very highly correlated. A high correlation between certain algorithms and blastulation can be obtained. But we must remember a high percentage of blastocysts never make babies. A significant percentage of blastocysts result in miscarriage. Some blastocysts make unhealthy babies. And here's a case in points. When we first used this technology, we discovered in these 9 embryos that 7 of them would be predicted to blastulate, and they all did, but they were all chromosomally abnormal. So actually, there is no real point in trying to predict blastulation. We know, of course, that every aneuploid embryo that at least is implanted, let alone made it to birth, was a blastocyst. So looking at morphokinetic data has been of real interest for at least a decade now. And I would have to say that I think of all the areas that are being looked at, they all have some value in some form or other. But the area around the blastocyst is probably, this area here is probably now more routine than ever and highly profitable. Let's just look, though, the overall morphokinetic review. There's a time-lapse meta-analysis by Prevensky and colleagues in 2017, and they did an RCT of morphokinetic algorithms on single time point morphologies, and these were at different stages. They looked at clinical pregnancy, live birth, early pregnancy loss or stillbirth. And of the 5 RCTs, which only totaled 1,637 cases, they showed a significant uplift in live birth rate and a decrease in early pregnancy loss. They stated, sorry, 1 second, because this is just don't know how to get rid of this. There we go. The time lapse is shown to significantly improve overall clinical outcome, which is something that of actual interest to everybody at the moment, because it's a huge debate. Now, as I said, I think probably looking at the blastocyst area alone provides enough data with good blastocyst cultures to use an algorithm fundamentally around that point, the time to the start of blastulation, the increasing in the blastocelic fluid, etc. But I would add a word of caution here. What's extremely important is the annotation of the actual time points, and whether or not, if you have a group that has multiple embryologists, whether or not they all agree at the point of annotation. And so it's quite critical, I think, with a whole raft of embryologists to ensure that you can get a very, very tight coefficient correlation between the individual, an inter correlation between each practitioner, so that when they annotate, you can believe the annotation is as if any one of them were annotating, so you can use that data reliably. Otherwise, and I have seen this, that there are quite huge variations, which in a sense then doesn't give you the true potential prognostic information that's required. So we published some work on this, several papers in recent years. We first of all looked at live births after using morphokinetics. And this was based on 973 deliveries, because the real interest here is not, whether you get blastulation, whether you get implantation, whether you get a clinical pregnancy. It's whether you get a live birth. Now, in our time-lapse work, nearly 37 was the mean age of the woman versus 35.3 in the standard incubation. Now, we know that you lose live birth rates of about 9% per in a yearly increment in the age of a woman over the age of 35. So already you'd expect there to be a compromise with the time-lapse approach, simply because of the age factor. The other thing that we learned, which is very important, and when anybody, I always say to my students now too, when you're analyzing a publication on live birth outcome, whether it's time-lapse imaging, whatever it is, you must assess whether the paper deals with the compounding factors that may affect outcome just as much as the embryo. And when we did this with our statisticians, it turned out that everything in bold here actually has a compounding feature to live birth outcome at one level or another. And therefore, they all must be taken into account before you can simply say the implantation rate or the live birth rate is significantly higher in group A versus group B. if the patient compounding factors haven't been taken into account. So in this publication, we had 24,000 records of treatment. We had, as you can see here, nearly 15,000 unique patients, 2,500 of the time-lapse, where we particularly use the embryoscope in the time-lapse work, compared to the meta-analysis of Pravinsky et al.'s group, where it was about 1,600. So it's big data. And we had various, I won't go into it now, statistical analyses, but at every point, except here at clinical loss, there was a significant difference between standard incubation and time-lapse imaging. And most importantly, the live birth events were significantly higher if time-lapse imaging was used. Having said that, it's simply crude. It's looking at live birth rate with time-lapse imaging and without time-lapse imaging. So we wanted to refine our studies. We can see here, if you look at, here we see overall means the stage of embryo transfer, generally a day 3 or a blastocyst. Just a single blastocyst, 5% uplift in live birth rate if we do time-lapse imaging the single blastocyst. This is an important note here. Over the age of 37, then the significance starts to be diluted. And I'll deal with that a little bit later in this talk. We decided to ask a second question. Can you rank the human pre-implantation embryo? So it's not that whether or not you've used time-lapse imaging or you haven't. If you are using it, then can you rank them? Can patients be lucky enough to have embryos that are more likely to make a baby than not, when others are unlucky enough not to have those quality of embryos? And true enough, when we did the data, when we did the study using single blastocyst transfer only, we used these various algorithms to grade our embryo. For example, if it was too difficult to grade, it was a D. If it was a C, it was time to the start of blastulation relative to the full blastulation number of hours, and less than that particular number of hours was a class A. And when you actually look at the data, we found a really significant difference between a class A embryo and the others. Live birth rate was significantly higher, and there was a reduction in the miscarriage rate. You can see here, just graphically, it was a nearly 48% differential between a group B embryo and a group A embryo. So from our particular data, with annotation that's tightly correlated, the laboratory using all the same protocols, the same culture media, etc., and the use of annotated embryos versus just standard conditions, we could actually get a distinguishing feature between different embryos. And if you look at the various computations one can do, then we, first of all, we concluded there was strong evidence of an effective embryo rank on the odds of live birth. And if you just compared an A to a D, the difference was a 233% chance of a live birth. So again, ranking the embryo was important. We then wanted to compare blinded study with morphokinetics and morphology, which is the standard alternative that embryologists are using. And again, we use single blastocyst transfers, single embryo transfers, 1,370 cycles, 73 cycles with, or transfers, with a 50% of those cases having live birth. And what did we find? We found that with the grading of the embryo, as I've already shown you previously, it was pretty tight, much higher live birth, 60% versus 40% for a grade A versus a grade B. But when it was blinded and compared to the morphology data that would normally have been used by the embryologist, we could see that there was no real correlation to the morphologies. In fact, actually, theoretically, a 1-2 classification of morphology would have been better than a 1-1. But if you had a 1-1, you would put that back as an embryologist. And so clearly, we found that time-lapse imaging was a much tighter and a much greater prognosticator than is morphology. And here you can see the rock curve here, which is very clear looking at embryo rank, which is the solid line here versus the transfer grade here, the morphology. Strong evidence superiority of time-lapse imaging embryo rank model compared with the transfer grade model. And some of you may well know that we published an atlas on all the different types of morphological criteria that one can see. I won't play this video now, but I'm sure many of you know that embryos can actually go through a reverse cleavage procedure where it goes from 2 pronuclei to syngamy, then cleavage to 2-cell, and then remarkably back to a 1-cell again. And you would never see that without time-lapse imaging. So the point I'm trying to make here is that irrespective of morphokinetic data, simply imaging data is extremely important because we now see a whole raft of cleavage anomalies like reverse cleavage that have a very low predictability for live birth outcome. But this particular embryo that goes through reverse cleavage was a normal 4-cell on day 2. And you would never know it went through this reverse cleavage process if you hadn't done imaging. So simply imaging on its own is valuable. I'll just show you some other examples that are going on. There's the Ivy project, and this was published by David Gardner's group, Tran et al. In 2019. And they were looking at a fully automated system to predict the probability of a fetal heart pregnancy. And they used information directly from the raw time-lapse videos without the need for many manual morphokinetic annotation, hoping to take away the bit of the human factor there, or blastocyst morphology assessment. And they looked at 10,000, over 10,000 embryos with nearly 2,000 unique treatment cycles in 8 different clinics in 4 different countries. So again, you know, if one was actually not using the raw data and using the individual annotated, then these would all have to be tightly controlled, but less so in this kind of study. And here was the ROC curve here for fetal heart pregnancy. Very, very tight curve of 0.93. And as they said, it was reproducible across the different laboratories with different culture and laboratory processes. It looked at just a single pass, which was very useful using this kind of technology, and is very different from how the embryologist analyzed the video. But the one limitation here, as I've already mentioned in my talk, is that the results were from a heterogeneous embryo, a heterogeneous group of patients, and therefore it didn't even take into really account the age, let alone all the other clinical factors that I've mentioned that is very important to use. So moving on quickly, there are others. There's a deep learning one from Khosravi studies. And, you know, the idea here of being able to use time-lapse imaging from a whole raft of different machine learning approaches, I prefer that to artificial intelligence, is now being looked at by a large number of groups, and it's promising, but I won't go into the detail of that. But I will move on a little bit to the chromosome studies. Many of you will have known the STAR trial from Illumina. Not very convincing when it is looked at, obviously, in terms of the outcome from cycle started and the utilization of embryos. But if you looked at it as single embryo transfer in terms of the time to pregnancy, then it can be useful in that the PGTA arm, now you can see this is an old slide, PGS, the PGTA arm was significantly higher than the control arm. And in fact, that mirrored very similarly our own data, which I just thought I'd show you because of the similarity there was considerable, in that we had a 52% live birth rate in the over 35 group compared to a 38% if aneuploidy was screened as opposed to it not being screened. Another interesting story here about potentially for embryo selection, which has been a bit of a goal of mine for many years and is now available, is looking at the annexin protein A5 and the what's called an M2 haplotype, which I'll show you what that is in a minute. But for those of you, I'm sure all of you are aware, but the annexin protein is very important for ensuring normal functioning of the placenta. It's highly concentrated on the apical surface of the syncytial trophoblasts. But if you get this mutation, which is a 4 base pair mutation in the annexin or the ANXA5 gene, you will have a protein affected so that there is a high risk of hypercoagulation and thrombotic risk in the placenta. This causes a whole raft of potential problems with the developing pregnancy. Just so you know, this is the sort of wild type, where there's a GATG at these positions here on the ANXA5 gene. There's an M1 mutation here. The one that's of real interest is this M2 mutation here, where you could see the G to the A, the A to the C, T to the C, and the G to the A. And it's been looked at in many, many thousand patients now in different ethnic groups around the world. And there have been several studies on this, but I won't go into detail. Simply to say, it's a placenta-mediated pregnancy complication risk, recurrent pregnancy loss. You've got fetal growth retardation. You've got preeclampsia. You've got embolisms and small for gestational age babies. The most important point here, though, is that it's embryonal, which is very different to any of the other thrombophilic potential conditions. It is independent of maternal and paternal transmission, in that if it's in the embryo, that's where the risk is. And so what I've been trying to do, which has now been succeeded, is to get possibly a test in the embryo so that one can either know it's there and treat it, heparin, low molecular weight heparin, for example, and study the risk of it or select against it. When we treated patients in this particular study here who had very poor outcomes because they were carriers, and we treated them with low molecular weight heparin, we almost improved their chance of a live birth rate similar to the controls. But of course, we didn't know what was in the embryo at that time. The other thing, well, just to mention that we now have a test for that. I'm going to just finish off with some work from Genomic Prediction, who've been able to produce that test. But we can now screen embryos if patients want. So we screen the patient with a saliva test. And if they want, we can now check the embryo to make sure that they have, whether or not they have the M2 mutation in the embryo, and then we can act on it. Finally, just to sort of finish off with, human health is extremely important. We all know that. We all know from the moment we're born, if we were forewarned or forearmed about some of our conditions, then we might be able to provide our lifestyle choices to improve our health for a longer term health benefit. But what's really interesting, and it's been coming up more recently in the last few years, is that infertility itself seems to be a marker, male infertility or female infertility, seems to be a marker for other potential health problems. For example, infertility may extend beyond gynecological cancers, thyroid cancers, and melanomas are particularly important apparently in relation to endometriosis. Unexpected increases have been shown in colon and uterine cancers with male factor problems. And overall, these studies point to a fact that with US men and women, the experience of infertility at any point in a woman's reproductive window may be associated with later life cardiovascular and other health issues. So to finish off with, I want to talk about some of the work at Genome Prediction. My colleagues there, who I rate very highly, have been doing some wonderful work. Not only do I think they have a fantastic PGTA, aneuploidy assessment program, they also look, of course, at the monogenics. They have developed a means to look at a polygenic risk score in embryos. And as you know, monogenic disease is only the tip of the iceberg of our health conditions. It's the polygenic disorders. You know, if you take breast cancer, for example, we all know about the BRCA gene, but it really is a small part of breast cancer. It's a polygenic condition, much more so. And now these guys are able to target these disease risks by screening the embryo for polygenic conditions. And this risk is growing larger. And in fact, they can do a lot more, but in terms of just looking at the really serious conditions, this is very important. So they would take an aneuploidy risk of the embryo. It's the same sample. You would look at your aneuploidy risk. They can overlay that now with a whole raft of those polygenic conditions. Let's just say coronary artery disease. So if these are your embryos, for example, this one you wouldn't choose because it's aneuploid, but this one and this one are euploid, and this one, however, has a 71% chance of coronary artery disease compared to this one at 19%. So you would have a choice as to whether or not you wanted to transfer an embryo or select an embryo on the basis of that information. And they've now refined this data to what is called an embryo health score. That's a -0.3. It's a euploid female. This is a euploid male, but that's got a 1.2. I'm afraid it's a bit fuzzy here, but you can see that, for example, if you look at the risk of heart attack here, it's down at about 6%, which is much lower here. In coronary artery disease, 37% versus 45%. And so in the end, they come up with this general embryo health score, where you have, for example, a group of embryos here. This one is embryo, just calling it number N1, but it was the first, it will be the first one of choice if you're interested in this technology because it's euploid and it has a high embryo health score, which means it's, for example, risk of heart attack and coronary artery disease is very much lower than any of these embryos, and they tend to follow with all the other conditions being lower as well. So that's a fantastically new, very exciting dimension to the selection of human embryos. To finish off, I think a strategy to maximizing live birth rate, and now I put in brackets health in the IVF scenario, is time-lapse imaging for all patients who are under 38. And I think that is now becoming pretty powerful for imaging, for kinetics alone. Over the age of 35, I think throwing in aneuploidy screening is sensible if time to delivery is important to you and your patient. And then I think it's important to state it's not mutually exclusive. These two can be done. And then along with that, if you are doing, you can also throw in, if you wanted to, screening for the mutation, if that's found in either the male or the female, because it's equally present in both. You can screen for the M2 haplotype in the same sample and also personalized health. That's if you're dealing with genomic prediction, who are the only group at the moment in the world who are able to do this. But I think we have come along in 40 years, being able to understand our embryos, understand the potential viability, and to be able, if we want, as a matter of choice, to be able to select an embryo to maximize the chance of a live birth, but also maximizing the health opportunity for a child resulting from that embryo for the rest of its life. Thank you very much. Did you get that okay?
Thank you a lot, Professor Simon, for this outstanding lecture. Thank you very, very much. Thank you.
Thank you. Bye-bye.
speaker, Professor Fisher? You hear me? Dr. Hajra?
Yep.
Yes?
Yeah. Hi.
You can share. Hi. You can share your screen, please.
Yeah. So thank you very much for the opportunity of presenting at this conference. My name is Hajra. I'm a trainee in obstetrics and gynecology in Birmingham, UK, and I'm also currently finishing my PhD looking at the outcomes of ovarian tissue freezing and transplantation. So I will start with a little bit of a background in terms of what ovarian tissue freezing is. So if you can see here, this is the histological section of an ovary. I know this is very small, but you can make out the cortex here, and all the white bits are essentially primordial follicles. And what you do in ovarian tissue freezing is essentially through laparoscopy or open surgery, remove a part of the ovary or the whole ovary, depending on the patient. If it's a pediatric patient, you're more likely to take the whole ovary out. You essentially take it to the lab, and cryobiologists remove the medulla. So this bit is the medulla, and so you remove the medulla and cut the cortex into small pieces, and they are as small as 4 × 8 millimeters and about 1 millimeter thick. So as you can see, they're very, very small, and they are then frozen using liquid nitrogen. So you can see the bit of the freezing process here, and then they are kept away. And whenever the patient's ready, you can thaw them and then transplant them back. So it was originally used in cancer patients, and spontaneous pregnancies have known to be achieved through this process if transplanted orthotopically, which means onto the remaining ovary or in the pelvic area. And you can also use IVF and other assisted reproductive techniques if required. And it's progressed quite rapidly, the ovarian tissue freezing and transplant process. It was developed over 20 years ago. However, the evidence on the success of this intervention is based on case series and case reports, and they're very sporadic, the data globally. And in terms of worldwide activity, you can see on the map, the concentration is quite a bit in Europe, but we've got a few centers in America, a few case reports reported in Brazil, Argentina. There was a few cases many years ago in India, and there's new centers coming up in Russia. Japan and Australia are also quite active. But in Europe, Belgium, Denmark, Germany and France are known to be the most active centers for ovarian tissue freezing. So the aim of this study was essentially to systematically review the current evidence. Like I said, it's all very sporadic, and there's lots of case reports and case series, and incorporate study level as well as individual patient level data and perform a meta-analysis. So we wanted to give an up-to-date account of the ovarian transplant activity globally, as well as provide fertility and endocrine outcomes from ovarian transplants, and that was to include fresh, frozen, and donor transplants. So to the best of my knowledge, there's no other systematic review that has included all the 3 categories. So what we did was we created a protocol which is registered on Prospero, and we conducted a comprehensive literature search from inception until October 2020. And in manuscripts where we could not find participant level data and we only had aggregate data, we also contacted authors and invited them for giving us patient level data. So we contacted 16 centers and we got reply from 6, and that included Belgium, Denmark, US, Russia, Australia, and one more that I've forgotten will come to me in a minute. But anyway, we had 222 patients for whom we had participant level data, and that included published and unpublished cases. So this is the PRISMA flow chart for the study. And so through searching, we came across over 20,000 abstracts, and after removing 679 duplicates, we still had about 20,000 to look at. We added a further 10 from hand searching and looking at references of some of the studies. So overall, for full text eligibility, we had 198. And in the end, we ended up including about 87 studies. So 13 of them had aggregate data. So this would mean giving us a mean of all the patient outcomes. And then for individual patient data, we had 388 patients from 74 studies. Now, to be able to do a meta-analysis, we needed to have cohorts. So we then divided these studies into studies which had 5 or more patients who had outcomes from ovarian transplant. So we included 20 studies in the meta-analysis. So 87 studies, 768 women, and this to date is the largest ovarian transplant database. 20 studies, like I said, reported 5 or more cases. So we performed meta-analysis on 601 women, and we looked at the fertility outcomes, which included pregnancies, live births, and miscarriage rates. And we also looked at endocrine outcomes from these transplants that included estrogen, follicle stimulating hormone, and luteinizing hormones. So in terms of reproductive outcomes, the pregnancy rates well, we looked at 18 studies, 580 women. And if you can see on here, the rates for frozen thawed tissues is 36, and then the cumulative is 37 for all kinds of transplants that were included. And at least one pregnancy was reported in 191 women. And the pooled pregnancy rates was 37%, and some women achieved more than one pregnancy. So overall, we found through our review that there were 300 pregnancies reported worldwide. Okay. And so then going on to live births, the live birth rate was 28% for fresh transplants, frozen thawed transplants only, and then the cumulative was 29%. So it was through 17 studies, 572 women, and we found that at least one live birth was reported in 141 women. The median number of live births per woman was 1 to 4. Some women obviously got pregnant more than once and gave birth more than once. So in addition to these studies, we also found a further 34 live births through our reports and case series. So overall, around 200 live births have been reported worldwide. And in terms of endocrine function from the ovarian transplants, so we looked at the levels of estrogen, and essentially what you can see is that there was an increase in the level of estrogen in women who had transplant, and almost all of these women were menopausal at the time of transplantation. So we know that the estrogen is not coming from an ovary that was already there. I mean, that ovary was menopausal. Whether this new transplant regenerated the old ovary, we don't know, and there is studies going on that, but they were definitely menopausal before they had the transplant. So the pooled mean pre-transplant was 101, picomoles per liter, which increased to 522. And for the purpose of this study, we gave a cutoff of 200 picomoles per liter. So if you achieved an estrogen of more than 200 picomoles per liter, we considered it as, yes, they have their endocrine function returned. And then going to FSH. So again, you can see that it favors post-transplant, and the pre-transplant FSH was 66.4, so that's clearly menopausal FSH, which decreased post-transplant to 14.1. And for the purpose of this study, we gave a cutoff of 25, that if you reached an FSH level of less than 25, then we would consider it as a return of endocrine function in that patient. So the median time to return of FSH to a value of less than 25 international units per liter was 19 weeks. And this is in keeping with the literature as well as return of menstruation. So it's around 19-20 weeks that you will see in some of the women have periods when they've actually been menopausal after their chemotherapy for years. So we also looked at other parameters, and we wondered whether age at cryopreservation had any bearing on the outcomes from the ovarian transplant. And what we found when we divided the participants in less than 35 and more than 35 years, that you're more likely to get pregnant if you had your tissue frozen at less than 35 years of age. So if we look at numbers, so out of the 768 patients, we explicitly had age for 319 at participant level. And of those, 283 had their ovarian tissue retrieved before 35. So I think there is already a consensus that we should be freezing tissue at less than 35 years of age if we want to optimize the chances of getting pregnant later. And then we did a further subgroup analysis, like I said, and yeah, you were more likely to get pregnant if you were younger. In terms of FSH, the results were not significant. The results were not significant, but you could see that FSH was much lower in women who've had their tissue transplanted before the age of 35 as opposed to after 35. We then also wondered whether anti-cancer therapy before cryopreservation had any bearing on the outcomes. And what we found was that there's not a lot of difference. I mean, we had only 122 out of 768 participants in whom we know whether they definitely had chemotherapy before, cryopreserving their tissue. And 56 out of those had received anti-cancer therapy. So 46% had chemotherapy, and 35 pregnancies and 24 live births were reported. Their mean age was 29. And we performed a meta-analysis, and like I said, we didn't find much of a difference, which is kind of it is reassuring, because it should not stop patients from going for this procedure should they prefer this to other fertility preservation methods such as egg freezing. So having anti-cancer therapy before that shouldn't deter them from going for ovarian tissue freezing. So in conclusion, I mean, this procedure may still be deemed as experimental by some centers. However, a lot of women a lot of centers are now offering this to women routinely. And in fact, the American Society of Reproductive Medicine have actually removed the experimental label from it. And the current ESHRE guideline on fertility preservation for females does say if this is a viable option in women, it should be offered to them. And we know from previous studies and from this systematic review and IPD meta-analysis that this could restore reproductive and hormonal function in women. And like I said, many experts are now considering this as a routine procedure. In addition to egg freezing, it's been offered. We have reported 300 pregnancies and 198 live births worldwide from this procedure. And there is probably more that are actually not published. And the mean duration of graft from this study, we found it was 2.5 years, but this needs to be, interpreted with caution, because it may well be more than that. We don't have large data over longer periods of time to actually see how long can a graft function for, and more often than not, a patient has more than one transplant over the years, so she may have a longer functioning graft. And one also has to take into consideration the baseline characteristics of these patients. So how old were they, what kind of cancer they had, did they have chemotherapy before cancer? If they did, what kind of chemotherapy or radiotherapy? So all those factors come into play when considering the duration of graft. And given the return of hormonal function, one does wonder whether we could also use this to prevent hormonal issues in women who have iatrogenic or even natural menopause. And of course, we need more data to prove how much tissue we need and where we could transplant it best and what have you. But it does open the discussion for whether this could just be used for hormonal function, because some patients don't want to have children after cancer, but they still want to lead a normal life and don't want HRT. So whether we could use this as a cell-based hormonal replacement therapy. And like I said, we of course need further studies with larger samples of very well characterized population to answer further questions, such as how much tissue do we need to retrieve, what kind of cryopreservation method should we use, slow freezing, vitrification. Slow freezing is the most common one for the ovarian tissue freezing procedure, but some centers are now doing vitrification and are actually also publishing live births from it. So we don't actually know whether one is better than the other. And then the transplantation process, how can we optimize the procedure better? Because we know that 70% of the primordial follicles actually burn when the tissue is transplanted. So it will go through the freezing and thawing process very well, but as soon as you transplant it, you lose so much of these potential oocytes. So how do we make that better? And there is no generic guideline. So there's lots of work that still needs to be done. And I think that's it for me. Thank you for listening, and I'm happy to take questions.
Thank you, Dr. Hajar, for this wonderful, excellent presentation. And if anyone has any questions, okay, thank you very much. We can shift now to Mr. Josh. Josh, he will talk about an important subject, which is the role of hydrosalpinx. Yes, you can share screen, Professor Joe.
Okay, hello. Can everyone hear me?
Yes, everything is okay. Yeah.
Okay. So, hello, my name is Dr. Jay Ghosh. I'm a clinical research fellow and trainee in obstetrics and gynecology from the University of Birmingham. So I'm going to be talking to you today about some of the work that I've done for my PhD. So my supervisors are Professor Kumaraswamy, Dr. Yanis Gallos, and Dr. Chu. And thank you very much to the organizers for inviting me to speak, as well as Mr. Afifi. So my talk is going to be divided into two. I'm going to spend the first half talking about a systematic review and meta-analysis which we published based on looking at hydrosalpinx and its effect on pregnancy loss. And based on what we found from there, I'm going to be talking about some primary research that we conducted looking at the role of fallopian tube patency and hydrosalpinx in our recurrent miscarriage population. So first of all, this was the systematic review and meta-analysis that we published. It was entitled Hydrosalpinx and Pregnancy Loss, a Systematic Review and Meta-Analysis. We published it, as I mentioned, in RBM online. And I'm going to start off just by summarizing what our study question was and what our summary answer was, and then go into some of the forest plots and the evidence behind it. So our main question was, what is the effect of the presence of hydrosalpinx on the risk of pregnancy loss? And our secondary question was, does the treatment of the hydrosalpinx mitigate that risk of pregnancy loss? And our summary answer is that for women achieving a pregnancy in the presence of hydrosalpinx, that hydrosalpinx continues to pose a detrimental effect on the pregnancy, and there is an increase in the risk of pregnancy loss, as well as an increase in the risk of ectopic pregnancy. Furthermore, treatment of that hydrosalpinx does appear to reduce the risk of pregnancy loss and reduce the risk of ectopic pregnancy when it's compared to no treatment. So we already know, because of the work of Annika Strandl in the late 90s and noughties, that the presence of a hydrosalpinx is not very good for IVF outcomes. So it's associated with lower implantation, lower pregnancy rates, and lower live birth rates in IVF and ICSI. But what was uncertain was that whether a hydrosalpinx continues to pose a detrimental effect once a pregnancy has been achieved. So that's what we were looking to find out. So how did we do this? We performed a comprehensive systematic literature search on Medline, Embase, Cochrane, and Web of Science from inception till July 2017 in all languages. We were looking for studies that compared pregnancy loss and miscarriage rates in women with a hydrosalpinx compared to women without a hydrosalpinx. And we also looked for studies that compared miscarriage and pregnancy loss in women who had a hydrosalpinx compared to women who had had treatment for a hydrosalpinx. Conduct was routine for systematic review, so study selection was conducted independently by 2 reviewers. We used the Newcastle-Ottawa scale for quality assessment of observational studies and the Cochrane risk of bias scale for randomized studies. Data extraction again was conducted independently by 2 reviewers, and any disagreements were resolved with discussion or with involvement of a 3rd reviewer. And then we pooled all the relative risks using the Mantel-Heintzel method. We found 23 studies in total, of which 7 were randomized and 16 were observational. The vast majority, 22 out of 23, were actually looking at the IVF population, and only 1 was looking at natural conceptions. So our results are probably more applicable to the IVF population, but that was simply, a reflection of the work that had previously been done. So this is a flow chart of the process that we went through. So we started off with 2,680 citations. We were left with 109 after we had screened all the titles and abstracts. And then we excluded a further 86 based on full text evaluation of those 109 citations for the reasons that are there. And we were left with 23 studies. So our main result was, as I mentioned before, is looking at miscarriage in women with a hydrosalpinx and women without a hydrosalpinx. So from a meta-analysis of 14 observational studies, we showed that there was a 74% relative increase in the risk of pregnancy loss in women with a hydrosalpinx compared to women without a hydrosalpinx. And this is the forest plot showing that. So as you can see here, there's very good agreement with the majority of trials that the risk of pregnancy loss is higher in women with a hydrosalpinx compared to women without a hydrosalpinx. 74% of the risk ratio is 1.74, and quite reassuringly, the I2 was 31%, which means that there was not a significant amount of heterogeneity. So I think we can be confident about this effect. We also delved into subgroups. So we looked at biochemical pregnancy versus clinical pregnancy loss. And very interestingly, we found that the risk of a biochemical pregnancy loss, so before it becomes visualized on an ultrasound scan and becomes a clinical pregnancy, we found that the risk of biochemical pregnancy loss was more than doubled in women with a hydrosalpinx compared to women without a hydrosalpinx. So that risk ratio was 2.36. However, if we compared that to clinical pregnancy loss, so where that pregnancy has been visualized on ultrasound scan, we showed that there was a much more modest, probably not significant increase. So the risk ratio was only 1.14, and looking at the confidence intervals and the p-value, that is probably not significant. So this is the forest plots for biochemical pregnancy loss. As you can see, a good I2 of 43% and a very strong risk ratio of 2.36. So there's a clear indicator here, especially when you compare it to the clinical pregnancy loss forest plots, that hydrosalpinx seems to pose its greatest risk in the biochemical phase, sort of at weeks 4, 5, where in terms of pregnancy loss, so that's where the biggest risk for hydrosalpinx causing a pregnancy loss is. As I mentioned before, we also looked at treatment of hydrosalpinx. So we found a number of trials that examined miscarriage and pregnancy loss rates in women who had had their hydrosalpinx treated compared to untreated women. And from a meta-analysis of 7 randomized trials and 6 observational trials, we found that the pooled results showed that the risk of pregnancy loss was approximately halved for women who had been treated for their hydrosalpinx compared to those who had not. So there's a little bit of hope here that for women with hydrosalpinx, some of the treatments that we can offer, which may include salpingectomy, may include ultrasound-guided aspiration or tubal reconstructive surgery. So what I mean by tubal reconstructive surgery is salpingostomy, salpingotomy, neosalpingoplasty. There are a variety of different techniques which the papers described, and we group them all together under tubal reconstructive surgery. But there does appear to be a benefit of treatment for improving pregnancy loss rates. So this is the forest plot. We can see it's subgrouped according to study design, and very reassuringly, the risk ratios between the randomized trials and the observational trials are quite similar. And overall, the heterogeneity is 0%, which is very good, which again sort of quite reassures us that there is definitely some benefit in offering treatment to these women if miscarriage is a concern. Delving a little bit further into these treatments, as I mentioned before, there were 3 types that we looked at. So ultrasound guided, tubal reconstructive and salpingectomy. But what we found here was that actually there is much more of a significant effect with tubal conservational surgery and salpingectomy than there is with ultrasound guided aspiration. So the risk ratio for ultrasound guided was only 0.75. Which crossed 1, so there probably isn't a significant benefit for this, but there clearly is benefit of tubal conservational surgery and salpingectomy. We also did look at ectopic pregnancy loss, but these findings are probably not very surprising. So as I'm sure we're all aware that damaged tubes, leading to a hydrosalpinx, there is a more than tripling of the risk of ectopic pregnancy with women that have a hydrosalpinx compared to women that don't. So that risk ratio is 3.27, and this is the forest plot for that. So I think it's important that women with a hydrosalpinx, should they fall pregnant, should be routinely offered early pregnancy scans around 6 to 7 weeks after their last menstrual period, because they are at very high risk of that ectopic pregnancy. So based on this information, so we can conclude now and say that, look, hydrosalpinx is clearly a risk factor for miscarriage. But looking at tubal patency and looking at tubal function isn't really a routine investigation for when we see our women in our Tommy's recurrent miscarriage clinic. So I then went on to do some primary research, and this chapter of my PhD is entitled "The Role of Fallopian Tubes and Hydrosalpinx in Recurrent Miscarriage," and it was a prospective cohort study designed to look at how common the problem is, so the prevalence, and also what the prognosis is of these women. So our study questions were primarily, what is the prevalence of blocked fallopian tubes and hydrosalpinx in the recurrent miscarriage population? And our summary answer is that the prevalence of blocked fallopian tubes, and not necessarily a hydrosalpinx yet, but the fact that the fallopian tubes were blocked, and our prevalence was 36.7%. So that's quite a high percentage. And the prevalence of hydrosalpinx itself was 6.2%. It's difficult to sort of compare this to the general population. We know that in the IVF population, it's probably going to be about sort of 15% or so, but we don't really know what it is in the general population. And what is the prognosis of women with recurrent miscarriage and concurrent blocked tubes and hydrosalpinx? So we can say that women with blocked tubes have lower pregnancy rates. Women with blocked tubes are also twice as likely to have a pregnancy loss or miscarriage. And lastly, women with blocked tubes are less than half as likely to have a live birth beyond 24 weeks of gestation. So those are some quite important things that we can begin to say to these women. So how did we go about this? So as I mentioned before, our methodology was a prospective observational cohort study. It was conducted at a recurrent miscarriage clinic in a large tertiary specialist women's teaching hospital. We recruited 137 with recurrent miscarriage between February 2018 and September 2019. They were all aged between 18 and 45 with a history of 2 or more miscarriages or pregnancy losses. So we were using the ESHRE European guidance on the definition of recurrent miscarriage. We managed to perform hycoses or hysterosalpingo contrast sonograms on 81 women to detect tubal patency. And we followed these women up for their reproductive outcomes for a year. So for those of us that don't scan, this is what a normal hycose looks like. So here we see the transvaginal probe. This is a transverse view near the fundus. And we can see this is the uterine corpus here, this dark area, and these 2 echo bright lines here, which represent the flow of the contrast, which has flowed into the uterine cavity via a catheter, which has been introduced into the cervix, and it's flowing via the ostia into the fallopian tubes. And then by moving the ultrasound probe, you can follow and track the flow of the contrast media through the fallopian tubes, and hopefully you can see it flowing out of the fimbrial end around the ovary. So we approached 543 women, recruited 137. It did prove a little bit difficult to get some of the women back for this specialist scan because it had to be organized at a very specific point early in their menstrual cycle to avoid the risk of pregnancy. We performed 81 scans. 2 women did not tolerate it very well and did not want to come back for another try. So 79 hycoses were completed, and we managed to obtain follow-up data at a year's time for 75 of them. And these were the baseline characteristics of the study population. So obviously the numbers that we had in the trial, relatively speaking, are small. So there are some differences here, which means the results that I will give shortly must be taken in the context of these differences. But reassuringly, one of the biggest risk factors for miscarriage is age, and there was a very good agreement between the 2 cohorts in terms of the age. So we can see that the mean age was 34.5 and 34.6. There was a slightly higher median BMI in the blocked tubes group. Similar proportions in terms of ethnicity of white Europeans, but differences between the South Asian and Black populations that we recruited. Similar proportions again for smoking, which we also know is a risk factor for miscarriage, but some small differences. We also looked at other baseline characteristics such as alcohol, caffeine consumption. And again, there were some small differences because of the smallish nature of the study. But importantly, looking at parity, we can see that in terms of previous pregnancy losses in the first trimester, the median parity was the same for both groups, which again is reassuring. And finally, other risk factors for recurrent miscarriage. So similar proportion in both groups had never previously suffered from any sexually transmitted infections, and small numbers had had gonorrhea and chlamydia, which are risk factors for pelvic inflammatory disease and tubal damage. And again, there were small numbers here of other clinical risk factors such as methotrexate for previous ectopic, family history of recurrent miscarriage, etc. So moving on to our results. So I'm just going to firstly talk about non-tubal abnormalities. Now, whilst this study was primarily looking at tubal abnormalities, because we were doing an ultrasound scan, we did find other abnormalities. So we found more congenital uterine abnormalities in the cohort that had blocked tubes. We found more polyps in the cohort that didn't have any blocked tubes. But again, there was, these numbers are relatively small. So I don't think very much can be drawn from this. But in terms of our headline results, so we're talking about the prevalence of these tubal abnormalities. So out of the 81 women who attended for a high COSY scan, 5 had the sonographic appearances of a hydrosalpinx. So that gives a prevalence of 6.2%. In terms of blocked tubes, it was a prevalence of 36.7%. Now, of those 29 women who had at least one blocked tube, just over half, one of their tubes was blocked, and just less than half, both of their tubes appeared to be blocked. And in both of those groups, the blockage appeared sonographically at least to be proximal in the vast majority in both of those groups. And then, as I said, the second part of our study was looking at the prognosis of these women. So we followed them up after a year. And here we can see that it's reassuring that the vast majority in both groups were both actively trying for a pregnancy, and there is no statistical difference in between that. We can also see that the vast majority in both groups were also using natural methods, so unprotected sexual intercourse, and a handful in each group were also using IVF and ovulation induction. So the most important one of the most important results in this table is the positive pregnancy tests since the high COSY. And we can see here that in the group with at least one blocked fallopian tube, there was a difference. There was less positive pregnancy tests since that high COSY. And we can see that there is a difference, and it is statistically and clinically significant. So that's why we are saying that women with blocked tubes have lower pregnancy rates. And then also in terms of pregnancy loss, we can see here that the numbers of pregnancy losses in the group with a blocked tube is significantly higher. So that relative risk is 2.01, so 100% more chance of a pregnancy loss. And looking at the confidence intervals and the p-value, that is a clinically significant and statistically significant result. And also looking at live birth greater than or equal to 24 weeks, again, we see that in the group with blocked tubes, you are much less likely to have a live birth at greater than 24 weeks of gestation. So my key messages from the research that I've conducted are that hydrosalpinx definitely appears to increase the risk of pregnancy loss, but that salpingectomy or tubal conservational surgery does reduce that risk of pregnancy loss. And then from the primary research that we conducted, women with blocked tubes may have lower pregnancy rates, higher pregnancy loss or miscarriage rates, and lower live birth rates than women with patent tubes. And it's important that as professionals that are caring for women with recurrent miscarriage and sometimes hydrosalpinx, so they are counseled about this. So we must ask ourselves that in women with recurrent miscarriage, where all routine investigations have come back negative, should fallopian tube testing be considered as part of routine testing, or as a first-line investigation, or perhaps as a second-line investigation? But I think a lot more work in this area needs to be done before we can sort of confidently say this, but there's definitely a signal of impact of the tubes and hydrosalpinx on miscarriage. Thank you very much for listening. Happy to take any questions.
Thank you very much, Professor Josh, for this wonderful, excellent presentation. And now I invite Professor Justin for his presentation about systematic reviews of tubal surgery outcome. You can share your screen, sir. Thank you.
There we go. Hopefully you can all hear me. My name's Justin Chu. I am a subspecialist IVF consultant and reproductive surgical consultant, I should say, at the Birmingham Women's Hospital over in the UK. And I just wanted to say a big thank you really for inviting me to come and speak. My first registrar job was actually with Mr. Yusri Afifi, who has always been very kind to me during my career, and he was the one that asked me to come and talk to the Egyptian sort of reproductive medicine and surgery field about something that's very close to both of our hearts. And I think you also embrace the topic of tubal surgery. And so I'm delighted to be able to present some findings of a couple of papers that we published over the last 5 years or so. So this is the team that I'm presenting on behalf, really. At the time, these are all of the individuals that are involved with this paper. I need to just declare that I do get a bit of sponsorship from a couple of pharmacology companies, Pharmacia and Ferring, but I'm really presenting on behalf of the reproductive physiology and surgical team here at the University of Birmingham, the Birmingham Women's Hospital. So really, I think what I was asked to present today was when to use tubal surgery in the era of modern reproductive medicine practice. I mean, most developed countries now have numerous IVF units. Certainly in the UK, we've got a high number of IVF units offering high and low tech question. But what I wanted to really do, first of all, is ask you all a quick question just to reflect on your own practice. And we'll talk about distal tubal occlusion and then proximal tubal occlusion and some interesting data that you can actually provide to the patients that you're seeing on a daily basis. So that quick question then, how, you know, obviously I don't need answers really, but just have a think about your own clinics, about what you do there. In terms of the type of tubal surgeries that you perform and who you offer it to. And certainly our practice in the UK is that, unfortunately, you know, women's age and obviously women's ability to self-fund IVF treatment is really, really big factors in terms of their decision making, along with our decision making as well. And certainly 37 and normal ovarian would probably be treated a little bit differently to a 27-year-old. And so what I mean there is, just to give you a lay of the land in the UK, we offer one NHS funded cycle of IVF treatment to couples who are able to be eligible, and that's if they're non-smokers, if the female partner is at a body mass index of less than 30 and they've got no living children. So if someone's a little bit older or someone's a little bit younger, that really does impact on our decision making. So I'll give you for an example. So if you've got someone who's 27 years old with distal tubal blockage on ultrasonography and on laparoscopy, I think you've got a little bit more time to play with them in terms of trying to fix their fallopian tubes before committing to more definitive tubal surgery and then IVF. Whereas with a 37-year-old, I would put forward that maybe you have a little bit less time, and so therefore definitive tubal surgery may well be the way forward. But if that 37-year-old already has a child and wouldn't be eligible for NHS funding, it becomes a little bit more of a difficult dilemma, because you might want to offer some restorative tubal surgery to that 37-year-old, as she wouldn't be eligible for any state-funded IVF. She'd have to self-fund that. So if she's unable to self-fund, you could try and fix her tubes and try and get her to conceive naturally. So there's a lot of factors in this decision-making, and I'm sure things are very different in Egypt. I'd love to hear your thoughts after this talk, maybe. But so firstly, if we just talk about distal tubal occlusion, we all know, we all have a very good idea about how distal tubal occlusion happens when we get these really sort of severe hydrosalpinges appearing on the ultrasound scan when we're investigating women with infertility. And usually the pathophysiology is fairly well defined. Women may not remember about chlamydia or gonorrhea, but they may well have been treated. But this tends to cause acute PID, leading on to chronic inflammation within the fallopian tubes. And as the tubes get damaged, you get distal tubular occlusion because there's no fluid, because there's nowhere for that fluid that's being produced within the tubal intima to go. It tends to accumulate with the fallopian tube, and that causes hydrosalpinx. And I think, as Jay mentioned earlier on, we know from work done by Annika Strandel's team in the early noughties in Sweden that actually that hydrosalpingeal fluid is very, very damaging to any embryo that we replace back inside the uterine cavity. So, you know, that work was started by Strangler, but there's actually been a brand new review that was published by one of our PhD fellows, Pedro Mello, in Cochrane. And that was literally last year. So that was looking at surgical treatment for tubal disease in women due to undergo IVF. And they're very clear. They found a total of 11 RCTs, not a great deal of women, 1,386 women who had hydrosalpinx prior to IVF treatment. And actually, when comparing salpingectomy for the affected tube versus no treatment, they found that the clinical pregnancy rate was roughly double. And that was in 4 RCTs, including 405 women. There was less evidence for tubal occlusion, but it seems to be very clear evidence that if we occlude the tube or remove the tube and stop that hydrosalpingeal fluid getting inside the uterine cavity, we have a big beneficial impact on the chances of pregnancy in IVF treatment. So much so, really, that no trials really get done these days because it's just shaped modern reproductive medicine and surgical practice that if we see damaged fallopian tubes with distal tube occlusion, that we remove the tubes or we clip them proximally so the fluid does not get back into the uterine cavity to cause those embryotoxic or mechanical washout effect on any embryo that we put inside the uterine cavity. And like I said, no treatment, we know, half success. So that shaped modern hydrosalpinx management in the infertility population. And what that leaves us with that is that really difficult conundrum, isn't it? So if we know that we've got a woman, whatever age, who's got bilateral hydrosalpinx and remove both of her fallopian tubes, then unfortunately what you are ensuring is that she is reliant on IVF treatment to try and get pregnant in the future. And as I mentioned to you before, certainly in the UK, there may well be funding restrictions that make it difficult for that woman just to say, yeah, take both of my fallopian tubes out because I've got mild hydrosalpinx and make me pay for all IVF treatments in the future. But there is an alternative strategy. So for those that are a bit older than me, I'm still relatively young in my reproductive medicine career, but there is an alternative strategy. So before IVF was widely available, it was the role of a tubal surgeon to fix these fallopian tubes. And for distal tubular occlusion, as has been presented in the previous presentation, there is the option of conservative tubal surgery in the form of a salpingostomy. And that's what led us really to think about alternative strategies in treating hydrosalpinx in women with infertility. And we ran a pretty simple systematic review and meta-analysis. And the data that we found was actually really interesting. So we were able to include, these are all actually cohort studies. These are 10 cohort studies that we're able to include that reported on live birth rate. So who were doing salpingostomy in women with hydrosalpinx. And what we're able to find is that the pooled live birth rate from these cohort studies is actually around 25%. Now, you might say that that's pretty low, given that, you know, IVF would expect a 40 to 50% live birth rate, but it really depends on whether that woman has access to IVF from a financial perspective. So this remains a really, really useful strategy for women with tubal infertility due to distal tubal occlusion. Now, with that meta-analysis, we actually looked and pooled the pregnancy rates according to the time points that each cohort study reported on. We found something pretty interesting. So you get up to 25% live birth rate at 2 years. So what does this mean? It means that if you've got a woman in front of you with hydrosalpinx, you can probably confidently say that they've got a 1 in 4 chance of natural conception if we do restorative tubal surgery in the form of salpingostomy, and that if they're not pregnant after 24 months, then their chances of live birth rate actually plateau. So at this point, that's the kind of watershed point that you should be saying to women, right, let's now do some definitive surgery and really think about IVF, because if salpingostomy hasn't worked by this stage, we get this plateauing effect. And as you can imagine, you know, the pregnancy rates do rise at 6, 12, 18 months because the tube actually tends to recover after drainage of the hydrosalpingeal fluid from the salpingostomy. And importantly, like Jay said in the previous presentation, you do need to obviously counsel women really accurately. And in our meta-analysis, we're able to find that the pooled ectopic rate was 10%. Okay, so, I mean, this is great. We've got a bit of data that we're able to provide women with distal tubal occlusion, but we need to be mindful there's quite a high degree of clinical heterogeneity in these studies. Some of them, tubal surgery was done open through microsurgical techniques. Some of them were done laparoscopically. Some of them involve cuff salpingostomy and non-cuff salpingostomy. And clearly there's going to be a high degree of publication and reporter bias here. Interestingly, because of Annika Strandel's work in the early noughties, as I mentioned to you before, there isn't many studies now looking at salpingostomy. And all of the publications that we're able to include back in a little bit older, so ranging from 1972 to 2014. And unfortunately, there's been a real loss of skills in terms of tubal surgery, with a kind of reliance on just removing the tubes or clipping the tubes and then relying on IVF treatment. But what I would say is that we've got better equipment than we've ever had before for laparoscopic surgery. So we should really be adopting this strategy in particularly young women with milder forms of hydrosalpinx that might not necessarily be visible on ultrasonography. But what about proximal tubal obstruction? I promised you that I'd talk about that as well. Similar sort of pathophysiology with proximal tubal blockage. Similarly, you get chlamydia, gonorrhea, followed by pelvic inflammatory disease, and then chronic inflammation of the proximal ends of the fallopian tubes, salpingitis, isthmic nodosa, and then you get that proximal tubal occlusion with this characteristic appearance of the dye only reaching the cornu of the uterus on hysterosalpingography. But are these patients limited then to just IVF, or is there anything else that we can do? And of course there is something we can do, and that would be tubal catheterization. So similarly, we then went on to report on a meta-analysis of cohort studies done on tubal catheterization for proximal tubal obstruction in 2017. And both these papers were accepted by Human Reproduction. So not quite as good as distal tubal blockage, but your overall pooled live birth rate, so not just clinical pregnancy rate, but live birth rate from these observational studies was 22%. And again, you might sort of scoff at that and go, well, that's not as high as IVF. But again, if a woman can't afford to continuously pay for this, pay for IVF treatments, then maybe she could fund some tubal surgery for continued efforts at natural conception. So again, you get this plateauing effect around 2 years. As you'd expect, really, there's sort of less of a sharp rise with time within the first sort of 12, 18 months. And that's because with tubal catheterization, we take a hysteroscopic approach, and then using a guide wire and salpingography, we're able just to sort of poke a hole where the tubal ostia is, looking hysteroscopically, to try and enable dye to be able to be passed whilst we're concurrently also doing a laparoscopy. Ectopic risk for tubal catheterization we found was, sorry, I can't see it down here was 4%, so lower than salpingostomy. But yeah, this offers us some really useful data to provide for patients who are considering proximal tubal obstruction surgery. So again, there's a lot of clinical heterogeneity, lots of different techniques that are being used, and we must remember that a lot of surgeons who'll be reporting their data will have very favourable results. And again, there's that 6-month plateau that we're seeing. So perhaps if that blockage, if we've unblocked a proximal tubal blockage and at 6 months the patient's not actually pregnant, we should probably think about offering IVF treatment in those cases. And again, case selection is key, but it just does provide us an alternative strategy for these patients who might not be able to self-pay for IVF. So just a summary really of what I've provided, it seems as though if you're offering salpingostomy for hydrosalpinx, patients have roughly about a 1 in 4 chance of a live birth rate if you do that surgery. And for proximal tubal occlusion, you're talking roughly between 1 in 4 to 1 in 5 chance of achieving natural conception. Like with any surgery really, case selection is going to be key. There's no point in trying to fix fallopian tubes that are really severely affected with hydrosalpinx, that are really never going to work because the architecture of the tubal intima is completely gone. So picking and choosing the right cases is obviously paramount. But I would sort of urge everyone who's willing to listen, and certainly reproductive medicines and surgery specialists of my generation, to really think about these alternative strategies moving forward rather than just relying on IVF. So just big thank you really for, again, the opportunity to present this data to you all. I'm happy to take any questions, and obviously I have other research interests too. We look at endometrial fluid metabolomics here in Birmingham, and also the impact of vitamin D on IVF. But that's all I've got to present to you. Thank you.
Thank you, Professor Shu, for this wonderful lecture. And now we are closing the online session, which is transmitted directly from UK. Professor Sham, the floor is yours. Thank you very much.